My name is Cameron Staples, and I'm a student at California Southern University pursuing a doctorate in psychology. Today, we will be briefly overviewing the opioid use disorder, highlighting the diagnostic criteria, prevalence and impact, and evidence-based assessment options. Opioid use disorder is a global concern, with nearly 450,000 opioid-related deaths worldwide and 39.5 million people diagnosed with opioid use disorder in the year 2021. This makes assessment, diagnosis, and treatment of paramount importance. There are several types of opioids. There are natural, synthetic, semi-synthetic, and then morphine we'll talk about separately. Natural opioids come directly from the poppy plant and include medications such as morphine and codeine, both of which have been used medicinally for pain relief for a long time. Then there are synthetic opioids, which are completely man-made in a laboratory. Some examples include tramadol and fentanyl, with fentanyl being particularly potent and a major contributor to the opioid crisis. Semi-synthetic opioids, which are derived from natural opioids but chemically modified, include oxycodone, hydrocodone, hydromorphone, and oxymorphone, all of which are commonly prescribed for pain relief, but also have a high potential for misuse. There's methadone, which is synthetic. However, it is used for medication for opioid use disorder to help people reduce or stop their opioid use in a controlled and safe way. It helps reduce symptoms and the urge to use. Opioid use disorder, or OUD, is a serious medical and mental health condition that requires a thorough clinical evaluation for diagnosis. According to the American Psychiatric Association, the DSM, or Diagnostic and Statistical Manual of Mental Disorders, outlines several criteria for identifying this disorder. To be diagnosed with OUD, an individual must demonstrate a problematic pattern of opioid use that leads to significant impairment or distress. This pattern must be at least 2 of the specified 9 criteria within a 12-month period. This diagnostic criteria helps clinicians to assess the severity of the opioid use disorder and guide treatment planning. Identifying the condition early is critical in connecting individuals with the appropriate care and support they need. There are 9 different criteria that help identify OUD in an individual, and they only need 2. The first is the individual will take opioids in larger amounts or for longer periods of time than intended. They can also experience a persistent desire to cut down or control their use, but they're unable to do so. The individual may spend a lot of time obtaining, using, or recovering from their use. And they experience intense feelings of cravings or a strong urge to use opioids. The individual may fail to meet major responsibilities or obligations. It can be at work, school, or home due to their opioid use. The individual will continue to use despite knowing that it contributes to ongoing physical or psychological health problems. The individual may persist in opioid use despite ongoing social or interpersonal conflicts. So it's interrupting their family life or their relationships with their spouse, but they continue to use. The individual may give up or reduce important activities or hobbies or responsibilities because of the opioid use. And using opioids in a physically hazardous way or situation, so putting themselves in harm's way, for example, using or sharing needles to obtain the high, knowing that it's bad, but still doing it anyway. There are 2 key features of opioid use disorder. There are tolerance and withdrawal, both which play a major role in the cycle of addiction. Tolerance develops when a person needs increasing amounts of the opioids to achieve the same effect, or when the same amount no longer produces the desired response. Over time, the body adapts, making the drug less effective, which can lead to an escalated use. Withdrawal occurs when opioid use is reduced or stopped, leading to a set of distressing physical or psychological symptoms. This is known also as withdrawal syndrome, which can include nausea, sweating, muscle pain, anxiety, or really intense cravings. Research suggests that people with co-occurring mental health conditions like bipolar, borderline personality, or panic disorder, just to name a few, are more likely to experience withdrawal symptoms. And those with opioid withdrawal syndrome tend to report lower mental health quality or quality of life. To avoid these symptoms, individuals may continue using opioids or something that gives it the same effect, not necessarily to get high, but to prevent those withdrawal symptoms and to feel normal. These two factors, tolerance and withdrawal, contribute to compulsive cycle of opioid dependence, making it difficult for individuals to quit without proper medical support. When diagnosing OUD, clinicians not only can identify its presence, but they can also specify its remission status and severity to better understand or communicate the individual's condition. Remission is categorized into two types. There's early remission, which applies when the individual no longer meets diagnostic criteria, aside from cravings, for at least 3 to 12 months. Then there is sustained remission, which again, no criteria is met, aside from cravings, for 12 months or longer. The severity of opioid use disorder is determined by the number of symptoms present. For example, a mild case would involve 2 to 3 symptoms, moderate 4 to 5, severe 6 or more symptoms. Another important specifier is if they are on maintenance therapy. This applies when a person is taking a prescribed medication, such as methadone, to manage their condition. In these cases, the individuals may no longer meet the diagnostic criteria for opioid use disorder, but their ongoing medical supervision is essential to support their recovery. Next is in a controlled environment. This is another specifier which applies when an individual is in a setting where access to opioids is restricted, such as a rehabilitation facility, hospital, or correctional institution. In these environments, opioid use is limited, not necessarily by choice, but by external factors. OUD remains a major public health crisis worldwide. Looking at global data, according to the World Health Organization's 2024 report, approximately 60 million people worldwide misused opioids in 2021. Of these, 20 million were diagnosed with opioid use disorder. Tragically, in 2019 alone, opioid use overdoses led to 125,000 deaths globally. Similarly, in the United States, the data from the U.S. Drug and Food Administration reveals that in 2021, 8.6 million Americans misused opioids. Among them, 6.1 million individuals aged 12 and older met the criteria for opioid use disorder. In 2022, the National Institute on Drug Abuse reported that opioid-involved overdose deaths rose from 49,860 in 2019 to 81,806 in 2022. Beyond the overall prevalence, certain populations experience disproportionate impacts. Research highlights several key disparities, including individuals who live in rural areas are less likely to seek help or receive treatment. Some of that is due to some of the barriers that they face, like limited public transportation and fewer facilities in their area. Young adults are also at higher risk compared to other age groups. Males are more affected than females, and minoritized populations face a disproportionate severe impact due to systemic barriers, which we'll talk about a little bit later. The prevalence of opioid use disorder and dependency varies by age and gender. Use among young adults is higher compared to other age groups, while use among adolescents is lower. It is still concerning because the continued physical, psychological, and neurodevelopment taking place at that stage in life. So looking at the prevalence of non-medical prescription opioid use and heroin, kind of broke it up into the two groups. According to the American Psychiatric Association, adults age 18 and older, their use, the OUD, ranges from 4.1% to 4.7% for prescription, non-medical use. While heroin use in this same group is lower, the range is still pretty high at 0.3% to 0.4%. Looking at young adults between ages 18 to 25, this represents the highest use age group. The prevalence for non-medical use is 5.5%. And for heroin, it's lower, but still higher than the other adults, is 0.5% to 0.7%, making this group a significant risk for use. Adolescents aged 12 to 17 are also affected, though at lower rates. Non-medical prescription opioid use ranges from 2.8% to 3.9%, and heroin 0.05% to 0.1%. OUD does not affect all racial and ethnic groups equally, and access to treatment remains a significant challenge. Data from the American Psychological Association and the Substance Abuse and Mental Health Services Administration highlight both the prevalence of opioid use disorder and the disparities in care. So among racial and ethnic groups, Native Americans experience the highest rate of opioid use disorder at 1.42%, then African Americans at 1.04%, non-Latinx whites close behind at 0.96%, and the rate among Latinx individuals is slightly lower at 0.70%, while Asian American and Pacific Islander, they're lumped together, they report the lowest rate at 0.16%. However, prevalence is only part of the issue. Access to treatment is another major concern. In 2022, 4% of the US population required treatment for OUD. Yet only 25% of those individuals receive medication-assisted treatment, and 30% receive treatment without medications. This means that nearly half of those in need did not receive any formal treatment at all. This gap is even wider for minoritized communities where treatment needs often go unmet due to systemic barriers, stigma, and lack of culturally competent care. Despite facing significant risks, these groups are often the least likely to receive life-saving interventions. When choosing an assessment tool for opioid use disorder, several key factors should be considered, such as population and setting. In primary care settings where time is limited, quick screening tools are ideal to identify misuse. However, in a substance use treatment facility, a more comprehensive assessment is needed to get a better understanding of the contributing factors and give a little context to the individual's use. Severity and chronicity of opioid use are also important to consider when selecting a tool. For individuals with mild opioid use, a brief self-report questionnaire may be appropriate to guide intervention, but for individuals with severe or long-term opioid dependence, a more structured and in-depth assessment, like an interview, a clinical interview, may be necessary to fully understand their condition, like I said, to gain a little context. Another critical factor is co-occurring mental health disorders. Many individuals struggling with opioid use disorder also experience conditions such as depression, anxiety, or PTSD. Other assessments like the Addiction Severity Index, the ASI, can be helpful in uncovering some of these coexisting conditions or psychological concerns that can be interacting or contributing to their substance use. That way they can be properly addressed. There are also cultural and socioeconomic considerations that can play a role in test selection. Language barriers and literacy level, the person's developmental age or chronological age do affect test selection, and they can affect the validity of a self-report assessment. Additionally, cultural attitudes towards substance use may influence how individuals respond to screening questions. So a self-report may not be appropriate if there is some response bias. To ensure fairness and accuracy, assessments must be adapted to be culturally sensitive and unbiased. Finally, it is necessary to acknowledge time and resource availability. In certain circumstances, tests can be really expensive and may not be the best choice for that setting. Also, in fast-paced settings where time is limited, brief screenings like the CAGE-8 or the ORT are practical and efficient. So selecting the right assessment tool is about balancing the efficiency, accuracy, and context to ensure that individuals receive the most appropriate evaluation based on their unique needs and the circumstances. When assessing OUD and other substance-related concerns, psychological assessments can play a crucial role in guiding diagnosis and treatment. A clinical interview and intake process can be useful in gathering information about individuals' historical and current use patterns and their experiences. This step allows for clinicians to gather pertinent background information, understand the individual's history, and assess the contents and cultural factors that may influence their substance use. A comprehensive intake ensures that assessments are tailored to the person's unique experiences. One commonly used screening tool is the CAGE-8 questionnaire. This is a brief 4-question screening designed to identify potential substance use problems. It stands for cutting down on substance use, annoyance from others, comments about their use, guilt related to the use, and early substance use in the day, like waking up in the morning and using early in the morning. A positive response to 2 or more usually suggests that a need for a further assessment. For a more structured and diagnostic approach, the SCID-5 is used. It's the structured clinical interview for DSM-5. Is a clinician administered interview that evaluates opioid use disorder based on the diagnostic criteria in the DSM. This tool is particularly valuable in determining co-occurring mental health disorders or concerns, ensuring that both substance use and any underlying psychological issues can be properly identified and addressed. In addition to the more in-depth interviews or a clinician interview that takes a lot of training for the clinicians to be able to administer those, there are several brief questionnaires that can be administered with little training, and they're used to screen for potential misuse, and often used in primary care settings or pain management clinics. There's the brief risk questionnaire, which is a 12-item tool designed to assess the risk of aberrant medication behavior, particularly opioid use, misuse, or abuse. And it's based on the brief risk interview. There's also the screener and opioid assessment for patients with pain revised. It's 24 items, and it's to kind of separate or stratify patients at risk for opioid abuse and misuse, usually administered during long-term, people who are receiving long-term opioid pain management. There's also the current opioid misuse measure, 17-item question, and it's a self-assessment tool designed to identify those who may misuse or abuse opioids. during pain management. And the last is opioid risk tool, and it's used to identify patients at risk for opioid misuse and abuse. It is only 5 items, which is great because it's quick, and it's a 0 to 3 low risk, 4 to 7 moderate risk, and 8 and higher high risk for opioid misuse. And it's widely used because it's so quick, and it's only 5 items, and it's successful, and it has actually been adapted to some bedside. It can be accessed from a smartphone, making assessment easy.